Good morning, good afternoon, and indeed good evening from wherever you join us from around the globe. My name is Tim Lane, and I'm editor-in-chief here at Surgery International. Surgery International is an online website which shares news and good practice from around the globe with nearly 20,000 surgeons worldwide. News features focus on surgical practice, innovative technology and robotics, as well as lifestyle issues affecting the surgical community. We celebrate the significant contribution of legendary surgeons around the world to our profession with in-depth features, allowing candid behind-the-scenes views of some of those who have and continue to pioneer progress in the profession. Our series of webinars in our Talk Surgery series, of which this is the latest, touch on a whole range of issues from artificial intelligence in surgery through to sustainability in healthcare systems. Today we're going to focus on peripheral vascular disease, and we're thrilled to be able to introduce to you a truly international expert panel. I'm going to ask them to introduce themselves before handing over to Mark Porto to chair the session. Given that as a urologist by trade, my knowledge of vascular surgery extends no further than the mobile phone number of my surgical colleague who I phone when I've cut something inadvertently, especially if it's pulsatile. But I'll be on screen throughout the event, and we'll be back at the end to put some questions to our panelists from those who have joined us live this evening a bit later on. So let's start with Mark. We'd like to introduce yourself.
I think you didn't do yourself justice there, Tim. We're the International Brotherhood of Plumbers, aren't we? Of a different sort. So welcome from London. My name's Mark Porto. I'm a consultant vascular surgeon. I'm joining you from the Royal Free Hospital, which is in London.
And Lorenzo.
Hi, I'm Lorenzo. I'm a vascular interventional radiologist. I've lived for 9 years in London in the UK. And now I recently moved to Florence, back to my own country, which is Italy, of course.
Okay, and Wilhelmine.
Hi, I'm very happy to be here. I'm a vascular and endovascular surgeon in Maastricht University Medical Center in the Netherlands.
And Kaji.
My name is Kaji Sridharan. I'm a consultant vascular surgeon based in York and delighted to be here today.
We may have someone joining us a bit later on, but they've not managed to log on yet. That's Tjun from Singapore. But if someone pops into the chat a bit later, I'll introduce them. So over to you, Mark.
Thank you, Tim. Well, as I said, good evening, everybody, and good evening to our esteemed panel. The title of our Surgery International webinar tonight is Innovations in Peripheral Vascular Disease. But I think it's clear from the topics that we sort of posted beforehand that our focus is going to be on very much arterial disease. Okay, so I realize that that does encompass the both sides of our surgical practice when we talk about vascular disease, but we're going to be talking about arterial disease really tonight. And I think it's clear again from our expert panel that we have a very strong pedigree here in endovascular surgery. I'm not suggesting in any way that our colleagues with a preference for open surgery are not innovators. Of course they are, but I definitely feel that we have plenty to talk about in the next hour on where we think peripheral arterial endovascular surgery can take us. So what I'd like to do, if that's all right, is just get started really by a topic that has always fascinated me when I've listened both to experts or when I've indeed had the opportunity to be on the panel and discuss it. And that's in the concept of vessel preparation. So this is something that can't really be disguised as a new innovation, but I think it's fair to say that there are advances at all time within this field and domain. So if I may, and put it to our panel, I'd like to know, firstly, can someone define it for me? What is vessel preparation? What is it that we hope to achieve by doing it? And talk us through your approach to it, please. Who wants to start?
Ladies first.
So, I mean, if I'll probably start then, if that's okay, Wilhelmine. But so my understanding, so I think we recognise that peripheral arterial disease is a heterogeneous disease and actually really difficult to tackle in that endovascular space. And there's a recognition that plain balloon angioplasty just simply doesn't work for most of the territories that we treat, and that's iliac SFA and Bologna disease. And the main Achilles heel is calcification. So the concept of vessel preparation is how do we modify that disease, that plaque, in order to facilitate that treatment. And I think that's where that concept has arisen. And in terms of vessel preparation tools or ways that we can modify it, I think it's intravascular lithotripsy, so blast the calcium, atherectomy, so those debulking techniques to try and physically remove that calcification in order to then facilitate that treatment, of such as drug-eluting therapy, and facilitate the drug penetration effectively to try and increase patency, but also improve those clinical endpoint outcomes as well.
Anyone else want to add to that? I think that was
yeah, we can add, like, for the people who are less vascular than us, we're just talking about having a vessel which is clogged. Could be like a chronic occlusion usually, so something like the artery is all full of calcium plaque and stuff. And usually the original treatment was to pass a wire, and over the wire to squeeze this kind of jam on the sides. And we realized that probably we are not removing this plaque, we're not changing the compliance of the vessel. So that's where all the things that Kaji said comes to practice, to improve the luminal gain that we achieve with our procedure, and ultimately the long-term patency of the vessel, ultimately the limb salvage.
I think in line of this reason of thinking, it's very important to plan and to prepare your intervention. Because the plugging, as you say, or the pipeline can be blocked by different substances. And it matters how you prepare your vessel and also what you leave or don't leave behind. So vessel prep starts already with preparation of your intervention, I think.
So how would you define it then? Because I don't think there's a clear definition.
No, I do agree with the definition that Kaji already mentioned. But I don't think it starts, I think it starts before the intervention already, that you have to think about what devices you can or may use and what might come in handy and what's not of use in your particular case. A calcified SFA needs another line of thinking than a soft plaque. So if you would have a CTA, for example, beforehand, you can discriminate between the both. In MRA, I find that difficult. So I'm very big fan of CTA, but it might be different for you guys.
Yeah, for me, I like very much like the duplex ultrasound. And actually, I try to also to have, I think you need to have all the devices on the shelves. Because it's, even if you can, it's not like a peripheral TIA disease is very much different compared to aortic disease. Aortic disease is all about planning. You come there with a plan and you stick to the plan. The moment you don't stick to the plan, it means you're in trouble. So the best thing is to stick to the plan, because the plan needs to be done properly. With the peripheral TIA disease, or at least is my Italian view, it's much more improvisation. So essentially, you go there, you have a plan A, and you need to have a plan B, C, and D. And during the intervention, you need to come out with a plan E, F, and G. So you need to have all the devices on the shelves in order to give the best appropriate treatment to the artery that you're treating. And then you need to go with the flow, let's say. And then what we didn't mention is scaffolding. You can prepare the vessel, but sometimes you need to put a stent. And, we know very much from the cardiology experience what a stent means. It's a little cage of metal which opens the artery and keeps the artery patent, at least at the beginning. Then that's the debate. How long will it last? Yeah.
I think it's important to mention that vessel preparation can also include a plain balloon. That in itself is a preparation. In fact, that was the preparation for the first 25 years of peripheral arterial endovascular surgery. But I think move very much in keeping with what Kaji said, what is it that we're hoping to achieve by it? And the answer is primary procedural success, of course, reduction in recoil, but also, as you've just mentioned, Lorenzo, reduction of reintervention, so improvement in the longevity of the treatments as well. And I think that's something that technologies that we haven't really touched on yet, we sort of mentioned about drug penetration, you mentioned, Kaji, but really, if I'm thinking about a very simple definition of vessel preparation, it is a procedure that is done to get the vessel ready for a definitive treatment, which, as you've just said, Lorenzo, could be a scaffold, a stent for everyone else. It could be a drug-coated balloon. or it could be another plain balloon angioplasty, potentially. Would you agree with that?
Or it could be a stent. So it could be a scaffold. But actually, Mark, I think technology is continually evolving. And whilst these concepts of vessel preparation in order to facilitate a treatment, there's also, if you look in the IVL space in terms of the iliac, there's this sudden shift towards actually thinking, well, intravascularity, so blasting the calcium to facilitate a stent, yes, that's one way. But actually, if you blast the calcium and you achieve that luminal gain, then why actually can't that be the treatment? And actually, that paradigm is shifting all the time. And I think that's why endovascular is particularly exciting at the moment, because these concepts are continually changing, continually evolving. Yeah. But we've talked about luminal gain and patency and reintervention, but the caveat, as always, to that is that we assume that luminal gain and impatency will translate to limb salvage, which is the really key endpoint. And that's not always the case, because there are other confounding factors to that.
That's a very good point. Absolutely right. What we were talking about here specifically are those endpoints that you've said, like luminal gain, patency. But you're quite right. That may be where it is one of the things that does hold back some of the literature that we read about with respect to the devices and otherwise, is they don't always have the endpoint of wound healing or resolution of pain. Very often, I think those endpoints are radiological or measured in terms of patency, exactly as you've said.
But then on the other hand, but we'll probably come back to that later, we also have the Basel III trial with a very relevant clinical endpoint, but maybe not the best endpoint for to test the efficacy of the devices tested. So it's difficult. It's a heterogeneous population, and it's difficult to choose an endpoint that it's both testing the device and relevant for the patient.
For anybody who's not familiar with the endpoint of the Basel III trial, it's amputation-free survival. And amputation-free survival is a composite endpoint of both freedom from amputation, but also overall survival, so mortality as well. And I've always personally, maybe it's my UK bias, felt that was a very sensible endpoint for for these randomized controlled trials. But that is absolutely true. I mean, this is one of the criticisms of the Basel III trial, isn't it? Is that it's not particularly suitable in this case. And I just wondered if you at this point we want to have a little bit more further discussion on that.
Well, if you look at the SVS guidelines on CLTI, it talks about a number of factors which will influence the outcome in terms of amputation. And one of them is the anatomical factors, which is largely what we're talking about when we talk about endovascular interventions and luminal gains. But the other factors is the patient itself and also the wound, so the Wi-Fi score of that patient. And I think that's the difficulty. You've got multi-level disease, and then you've got these other factors coming into play, which will affect your clinical outcome. So perhaps it is absolutely right that we focus, when you're looking at devices, that we do focus on a different endpoint.
What do you think, Lorenzo?
Yeah, I mean, I can tell, I just want to say the same thing, especially because, I mean, the group of patients with peripheral arterial disease needs to be divided in two groups. And one is a group of what they call the claudicants, so people who need to stop while walking because they have too much pain and they need to stop either 200 meters, 100 meters, 50 meters. And then the critical limb ischemia start. These are the patients who have either rest pain, so pain when they sleep because the gravity doesn't help the arterial blood flow to reach the foot, or even they have ulcers. And actually, these are the most difficult patients, especially the one with Rutherford 5 and 6. That means tissue loss, even extensive. You don't just need an open pipe going down to the foot in order to heal from these infections, tissue loss and stuff. Of course, the arterial blood flow needs to go there. If not, no antibiotics will go there, no tissue regeneration will happen, but it's not the only thing that matters. So essentially, this stress also the fact that the multidisciplinary team is very important for these patients, because everyone needs to take care of a little bit in order to get to the amputation-free survival, to the wound healing, because you can't just assume that by having an artery which is patent, then you have done your result. And actually, it takes a long time. It's not like the cardiac ischemia. You open the stent, the blood flow goes down to the heart, back to square zero. Here we're talking about the long process of wound healing.
I also think, sorry, go ahead.
Yeah, I was just going to add that if you look at the numbers from the best CLI, which are a trial in patients with clinical limb ischemia, you will have a selection of rather fit patients. And mortality was, I looked, that was about 30% in less than 3 years. And these are our fit patients with CLTI. So we're talking endovascular here, but deciding whether you go for revascularization in this patient is maybe even more difficult than deciding how you are going to revascularize the patient if you opt for that option.
And many times we go for a palliative treatment anyway, because we know from the literature that after 5 years, 50% of the people with CLTI die. And actually, from another study, 44,000 people from of course the U.S. database of the military hospital, the ones who have an ulcer, 30% are alive at 5 years, no matter how big the ulcer is. So of course there are subgroups, but generally speaking, 30%. So we're talking about a very bad cancer. But, at the same time, people have pain. So you can't leave anyone dying with a pain who doesn't let you sleeping. So that's, I think, is the key message. We can't deny treatment and appropriate treatment to these people.
And for those of you watching, we've just had Tjun's managed to join us now. And so, Tjun, would you just quickly like to introduce yourself and then we can carry back on with the discussion?
Sorry about this. Very good evening to all. I actually have just come out of the operating theatre, actually, so my apologies. It's about 3 o'clock in the morning in Singapore, so my apologies for being a bit late. So I'm one of the vascular surgeons from Singapore. I actually trained in the UK, in Cambridge, about 20 years ago. I've been in Singapore as a senior vascular surgeon for the last 10 years. I was previously at Singapore General Hospital in the public sector. Now I've gone fully private, and I've done basically most of my work is actually in lower limb revascularization. Actually, that's what we get a lot of here in Singapore, apart from aneurysmal disease. So we do quite a lot, and we use probably all the cutting technology, probably more than first before anybody else, because we're allowed to use it. So one of my subspecialty interests in research has been lower limb revasc, and I look forward to talking about some of the newer technologies that we've used from Singapore. Thank you very much.
Fantastic. Thanks, Tjun. I'll hand back to you now, Mark.
Thanks, Tjun. Welcome. I think you've got a really good excuse there, I have to say.
My apologies. No. Sorry, I'm just rushing in, and I'm apologies for joining you so late.
And 3 in the morning.
Quite a long OR schedule then. Yeah.
We're all impressed, Tjun. Tjun, we've just been talking about vessel preparation. Our discussion would very much led to the population of patients that we're talking about when we talk about CLTI, recognizing that the majority of them do not have a life expectancy. That sadly, that's something we're not really impacting so well with respect to outcomes. But I've always believed, just like Lorenzo mentioned, that CLTI should be treated very much like a cancer, and like a cancer whereby you perhaps achieve a remission as your best sort of outcome with respect to our treatments. And in so many ways, Lorenzo, I think you're right. When it comes to the delivery of a palliative care service, I came to that, I reconciled that years ago, that we are palliative care interventionalists in so many ways for this disease. So, Tjun, we were just talking about vessel preparation, and we mentioned lithotripsy in the calcified segments, pretty much in all territories actually, and how things have sort of moved on now, if anything, to avoid stents and otherwise. But what I want to bring the discussion to, and this is definitely still in the domain of vessel preparation and the sphere of CLTI, is what is the particular challenge of treating below the knee? And I wondered if you wouldn't mind starting us off about how you approach that, and what it is that you recognize for the listeners, what the particular challenges are.
That's a very good question. Actually, in fact, this is what really forms our problem in Singapore. The majority of our lower limb revascularization is CLTI. So in everyday practice, we deal with 95% CLTI, 5% claudication. In fact, claudication is very unusual in this part of the world because diabetes is a very big problem in this part. The prevalence in this country is actually really growing as such. So one of the big problems.
We'll come back to you in a second. I just want to quickly ask the rest of the panel then, is that the same breakdown across your units as well? So what Tjun said there is the vast majority of his practice, 95% or more, is CLTI. In London and in our practice here, I would agree with him. That's exactly how we treat things as well. How about you?
I think it's also talk about a different thing. Like in the Occidental world, we're more used to smoke. And smoke brings a disease which is more iliac and SFA. And actually, this like SFA superficial femoral artery. So the arteries which are going from the belly button down to the, let's say, the knee joint. What it talks about also is the difference in let's say physiopathology of the disease. Where we encounter many patients who have disease higher than the knee. He faces more, like in a percentage, more diabetic people who have, as we all know, microvascular disease. So the artery in the heart, the renal arteries, and the arteries in below the knee. So the three vessels which are reaching the foot. So I think that, in terms of CLTI, yes, of course, we're busy with our practice with these kind of critical patients. And at least also in Italy, we don't have space to treat the other ones. So we try to try to bring them to the limits with their physical exercise and let's say conservative treatment. But when we talk about vessel disease, if you go down to the below the knee joint, there's nothing really you can do to improve situation without any kind of revascularization.
Okay. Kaji, Williman?
Yeah, so if I was looking at UK practice markets, it's very similar to yours. So in the UK, we simply don't treat claudicants unless they are very young and have a significant impact in terms of their quality of life. So by far the majority of patients that we treat are patients with CLTI, and the burden of disease is it's multi-level disease, calcified disease, which is really difficult to treat. And actually, compared to 10 years ago, we're doing more and more hybrid procedures as well, where we potentially will open up a common femoral and treat both the iliac segment as well as the fempop and below the knee in a combined open and endo fashion.
How about in Maastricht, Williman?
And the majority will be CLTI. We do have a lot of claudicants as well. We aim to keep them at the GP and not have them in the hospital. But when they fail for supervised exercise therapy and have invalidating complaints, they will end up with us and we'll treat them as well. So I won't say it's 95%, but the vast majority will be CLTI patients. And I think most are multi-level, but we also have the diabetic population that you're talking about, Tjun. But we have a lot of smokers as well, as you say, Lorenzo. So it's not like a Singapore population.
No. So, Tjun, sorry to have interrupted you, but I just wanted that chance just at that juncture, just get an idea for the cross-section of, those of us in north of England, south of England, Italy, and of the Netherlands. We're all coming from a similar point of view, but perhaps with a slight difference in the distribution of the patterns of disease. So if I could ask you to continue, apologies for interrupting you.
Oh, no. It's very interesting to see how other people are finding this because one of the great challenges is actually of CLTI is dealing with the tibial disease. Probably 90% of this CLTI population here in Singapore are diabetic, and they're type 2 diabetic. A big problem with the vessels, and I think one of the big challenges is both the below the knee disease, but also below the ankle disease. Below the ankle disease probably forms at least about 15% to 20% of the problem as well. And actually revascularizing the below the ankle is even more of a challenge. One of the big barriers, I think, is calcification. Calcification probably forms at least in probably to moderate to severity terms, about 80 to 90% of the problem. And actually, that's why vessel preparation or even getting a wire across the calcium once you've done a CTO. CTOs probably form at least around 60, 70% of the cases, long CTOs. They're not just stenosis. Actually, crossing with a wire may not be a problem, but ultimately getting a balloon to cross without any kind of atherectomy or any self-help or even a flossing technique is actually sometimes quite challenging. So that's one of the big problems. And once the wire goes below the ankle, wow, that's the really bigger challenge. And that's where we have a big problem, actually, of trying to keep the vessels open. So vessel prep is very important from your point.
For our listeners, CTO, chronic total occlusion. So it's when the arteries are completely blocked. So this is the difference. Is the artery completely blocked or is it just tightly narrowed? And that's the difference between occlusive and stenotic disease that Tjun just mentioned. So Tjun then, what we're going to talk about then, if that's all right, maybe for the next 15 minutes or so, is your strategies to approaching both below the knee and below the ankle disease. What are your strategies then? How does it differ? And okay, why don't we start then? We'll come back to you for a second. For the rest of the panel, talk us through the difficulties and why the below the knee segment proves to be such a challenge for endovascular practitioners. Let's just put that into context for us, for our listeners. Lorenzo, you start us off.
Yeah, I mean, like the first thing is like the size of the vessels. Of course, if I open a vessel which is 12 millimeters down, let's say I open to 10, which I lose like 20% of my diameter, I still achieve a good, luminal gain. Of course, if the vessel is 2 millimeters, 2.5 or 3 millimeters, then the challenge is bigger, because the moment I lose a little bit of my let's say luminal gain because of recoiling, because the calcium recoils, because the calcium reacts badly to our treatment, then the vessel goes almost to occlusion. So that's why it's important to have a very, let's say, effective treatment also for a long length of occlusions. Because, I mean, when we talk about cardiac patients, yes, the occlusion can be very calcified. Maybe you have less possibility of access because you can't puncture the heart in order to get the wire through. But at the same time, it's easy to stent because these lesions are 3 centimeter, 4 centimeter, 5 centimeter long. In a complex critical limb ischemia patient, you get to 35, 40 centimeter long lesions. Essentially, it's difficult to also to focus on different parts of these lesions with very little, in a way, because we're talking about innovation, with very little tools, because we don't have very long stents, because they're coming from the cardiac experience. So essentially, some patients have a very long occlusion that are really difficult to treat. And as you mentioned, the below the ankle disease, I'm a big promoter of even considering these vessels, because many people, like, because of let's say the tradition, don't even look into these vessels. They say, oh, they are too small. They don't even take a picture of these vessels during the intervention. That's one of the biggest errors, because these are the vessels which are bringing the blood flow down to the ulcer. So if you don't bring the blood flow to the ulcer, because the blood flow stops the ankle, it doesn't matter what you have done, the amazing job you've done at the level of the thigh or the level of the knee joint, because you need to bring the blood flow down to the foot.
Absolutely. Kaji Williman, want to add anything?
I think I think actually Lorenzo brings an important point, as in, do you have a target vessel? And people's definition of is there a target to even attempt an angio varies. And there's also this concept of, are there hibernating vessels? Are there vessels that you simply don't see because there's such low flow into the foot that when you start revascularizing, improving the flow, that they suddenly start to open up. And we're quoted this figure about 20% of patients are no option patients, but that concept of no options varies between those who are really enthusiastic about revascularizing and trying to save the leg versus those that don't. Those are significant challenges, but if you've got a long lesion, how do you cross it? And actually planning is really key. So before you go into the intervention, yes, you can go from an antegrade option, so from the top, but also think about retrograde access. And Lorenzo, you're probably one of the kings of retrograde access. So think of what are the options and be aggressive, especially if you've got that patient with CLTI, where if you can't improve it, then there simply is no option apart from amputation. And actually, also, we've not talked about it, but think about percutaneous deep vein arterialization. That's a different concept to PARC, a conventional endo option, but think about different strategies.
Maybe I can add to that what you said about the desert foot. I once heard one of my colleagues say, and I find it it's a good statement, I think, if there really was no target, no vessel, there was no foot. So there must be something, but you might have to look for it a little bit closer. And what might help if you, I think that most of us will do that, is to insert a long sheath. So not to inject from the groin if you go from an antegrade fashion, but have a long sheath in the popliteal. To make sure that you get your contrast to where you want to see it. And then, I would always use an heparin drip to prevent clot forming on the sheath. To make sure that everything you just opened up doesn't thrombose. And in addition to that, you might use nitroglycerin or verapamil to keep the vessels open, or to have some vasodilatation. but still, I find it still a very intriguing, but also challenging part to treat. And indeed, you can go in a retrograde fashion. And what we do more and more now is also to look for a target for a pedal bypass. So that's not really the topic of today, but as you mentioned, the DVA, which is endovascular, but not really what we're talking about today. We're more enthusiastic about the very distal bypasses to the DPA or even to the plantar artery. So when I treat my patients, I try not to destroy a target for a good pedal bypass if I think it's a suitable patient.
So if I had to summarize, really, for the sake of the listeners, the challenges, particularly for below the knee and perhaps below the ankle intervention, it very much, as Lorenzo started us off, would be the difficulties with the long lesion lengths, the long disease segments of arteries, lengths that are far in excess of you would see in the coronary arteries, vessels of similar diameters, the very high tendency of these vessels to recoil after angioplasty, the difficulty with delivering drug and the failure that we've seen in using drug-coated technologies below the knee. We've definitely not seen a clinical benefit for doing so. And the difficulties with dissection and thrombosis. And as I said, 97% of the interventions apparently recoil almost within the first 15 minutes. So these are the challenges, and this is why below the knee and below the ankle interventions prove to be so difficult for us to treat. So what I'd like to ask, Tjun, just coming on to you, you mentioned that you had an opportunity very much in your practice in Singapore to utilize a lot of more novel technologies with respect to this segment. And I wondered if you could start off by talking us through that, because, you know, there's plenty for the rest of us to talk about too with respect to IVL, I would say perhaps even retrievable scaffolds, these sort of technologies. But Tjun, if you'd start us off just with some of the things that you've been doing in your below the knee practice.
So, you know, the below the knee segment actually on Asian patients, what I found having trained in the UK and having worked with Caucasian patients, you know, we did a lot more bypasses when I was in Cambridge. We probably did 80 a year. I actually only do about 3 or 4 a year now, actually, to be honest with you, since arriving. One of the things is that the vessels are about 20% smaller. So basically, you've got to get the luminal gain even bigger. So my practice has completely changed from using semi-compliant balloons to high-pressure, non-compliant balloons. And the one I go to and I favor is the jade balloon, basically, because it actually really gives it a great oomph to the vessel. So vessel prep to reduce the risk of recoil, especially in really calcified vessels. And then it's obviously going to have a trade-off between the cost and what you're trying to achieve. A high-pressure non-compliant balloon is actually a very good piece of technology, basically, to try and what's on the market available to force open that vessel before you do any drug. And I think it does a lot actually in our population of patients, even without the drug situation. So that's one aspect that I've found very, very useful without complicating things too much.
What do you do then with the problem of dissection? Because that seems to me a really obvious consequence of high pressure angioplasty with a non-compliant balloon, particularly in the below the knee segment. So what do you do about that problem?
So dissection, I mean, obviously there's different grades of dissection and where you would think about intervening. But obviously in any vessel that with very severe calcification, you're going to get dissection. But so long it's non-flow limiting, I don't see that being a problem of you needing to things like putting a scaffold or whatever for that. I think if you use the long balloons, you have less problems with the shouldering effect on where the high pressure. So where the pressure is concentrated is typically at the shoulder of those plaques. If you have long balloons, I think you can minimize those kind of dissections. The problem is that the CTOs, you do see a lot more dissection than you do with stenotic disease. So I'm not too afraid of leaving dissection and let it remodel basically. I remember when I was in Leicester all those years back, Aman Boli used to tell me about a dissection. Don't worry about it; it will remodel. You can go back in. Try not to do any stenting in that kind of scenario. I still do quite believe that to an extent, so long it's not as flow limiting. But what I want to see is some sort of reduction of recoil, because recoil is your big enemy here. And even in the event of severe dissection, severe calcification, I actually do DCB, and I use sirolimus technology actually to do that, because you can take the sirolimus balloon all the way into the foot without any problems with low flow problems. And I feel that that's one of the bigger problems where paclitaxel has been. I'm sure that's going to be coming up very soon at some stage. So why don't I stop there and ask the others actually to see what their thoughts are.
So can I ask you something? Because you were talking about high pressure ballooning that might increase the risk of dissection, but sizing is also a big thing. So how would you size then, Tjun and the others? Because I think that's one other factor, right?
I think as generally as practitioners, especially as a community, we actually undersize our vessels, tibial vessels greatly. I think we're undersizing by at least 0.5 to 1 millimeter. Some of my colleagues are using IVUS, which even adds more expense at putting an IVUS, an 0.14 IVUS, to right down the tibials to size it appropriately. So I'm a bit more aggressive, because I think with the high pressure non-compliant balloons, there's very less risk of rupture of these vessels. So I take approximately a 3.5 and sometimes even 4 approximately in a tibial, whereas some people will just take a 2.5. So really you're doing a patient a disservice by undersizing. So using IVUS technology, I think, is a very good way of assessing both the size that you're trying to achieve and also the dissection. But whenever you put IVUS in, you're more likely to stent as well.
I'd certainly agree with you regarding the undersizing of the vessels, and that's something we've seen countless times when compared to an IVUS gold standard. And personally, I use a lot of IVUS in my practice. Like Lorenzo, I go off duplex as our primary pre-intervention modality, which then really just determines access point. And then from that, then I like to think we try and save a bit of time, potentially save contrast, and certainly save radiation by then going on to IVUS on table. But interestingly, the approach that I have gone towards in my practice is actually away from high pressure non-compliant balloon angioplasty, particularly below the knee. And actually, I would prefer, if in the calcified situations, to oversize an IVL catheter, but do so at much reduced inflation pressures. So I would particularly, I know that there will be anatomical differences, size differences, by sort of areas of the world, predominant populations or otherwise. But certainly, I would much rather put, for instance, a 4 millimeter balloon, a 4 millimeter IVL catheter, but only up to 2 atmospheres, and then overlap that throughout the full shock allowance across the whole length of the vessel, but do so at only 2 atmospheres. So I actually have kind of gone in the opposite way to you there, Tjun. And what I find by doing that is I get significantly less dissections in doing that. Kaji, sorry, you wanted to say something?
I just a comment to Tjun, really, because in terms of the evidence base behind it, and with below knee, it's a really difficult, because you've described a practice of plain balloon and DCB, but the actual trials and evidence behind that, or DCB below the knee, isn't there. We know that with plain balloon, there's a high incidence of recall, and it's simply not the best strategy for below the knee. When we look at plain balloon and DCB, again, that evidence isn't there. And actually, we've got really small trials when we start to look at atherectomy and DCB, and whilst there might be a trend, it doesn't quite show significance. And with IVL, the best we've got is some registry data. So we're talking about technologies which are really expensive, where the evidence base isn't there, but we sort of justify its use because actually there are no other options, and we think we might be able to salvage the leg. So
I mean, I also think that we need to specify what these things means, because I don't think there are many vascular doctors. Maybe there are also very heterogeneous parts. So we talk about, it's more or less talking like to patients sometimes, because if the urologist don't know what IVL could be, So intravascular lithotripsy, for example, is something that was mentioned. So sonic waves, like, of course, the urologists, they break the calcium in order to change the compliance of the vessel. So essentially a vessel which is like rock becomes like jam, just because you break, like what I say, the windscreen around the vessel in order to achieve a better compliance of the balloon angioplasty, which can happen with the semi-compliant or non-compliant balloons, which means balloons which are more aggressive or less aggressive. And when we talk about IVUS, it's called intravascular ultrasound. So it's a technique where you put the ultrasound, instead of being outside, inside the vessel. So the IVUS goes through a wire which passes through the vessel. And by doing this, you can check with much more accuracy what's happening within the vessel. And actually, whenever you pass an IVUS in the BTK, and you see what the effect of your compliant, non-compliant, semi-compliant balloon, it looks always a disaster, because you can't really achieve the luminal gain that you hope, and you within your heart you think is going to be good for the patient. So essentially, that really pushes us to think maybe we need something long scaffolds, which could be the future. We have seen now the bioreabsorbable ones, for example, coming from the SPRIT trial, 2 years follow-up data now presented at FIVA in Vegas like 3 weeks ago. And we are seeing also another study which is coming from another company, R3, which like the stents are going to be 15 centimeter long, bioreabsorbable. So this, I think, is going to be the future. You prepare the vessel well, you scaffold it well, and then hopefully the patency rate will increase, and with that also the limb salvage rates.
Anyone, anything else to add on that topic? I think that sorry, go on, Tjun.
Sorry, can I just go back to Kaji's actually a point about the lack of evidence? I think that's a very good point. But one of the things that we are always trying to do is, obviously with CLTI, the size of the wounds is a big problem, because we want to keep the vessel open until that wound really heals. And we're trying everything that we can to try and do that. And I think just POBAR alone, I think just plain angioplasty alone is probably not going to be good enough. You're going to be your reintervention rates are going to be much higher. And that's why my kind of thinking is that you add another balloon or a DCB, can you actually keep that vessel open longer? Yes, the evidence is not there, but I've been very actually optimistic about use of sirolimus actually in the BTK region, especially going to foot. The luminal gain that you get, and actually when you put the balloon in, the flow looks a lot better as well actually afterwards. And we've managed to actually keep some of the Rutherford 6, or I would call Rutherford 7, if there's such a thing, basically. Huge wounds basically open without actually re-interventions. And that's only a personal experience. But I agree with her, absolutely right. There is not that much evidence, but we're trying our best here.
But Jenny, equally, there's quite good cost effectiveness data that suggests that actually multiple interventions is far better than, and actually more cost effective than, a major amputation. So, I'd agree with your strategy. I mean, it's a strategy that I follow as well. Doing something different is better than doing the same thing, which we know doesn't work.
In terms of innovation, sorry, I'm just going to sum this up now, if that's okay, guys. For sake of time, innovations in this area is something that I would identify as a key necessity to our practice. And it's certainly true that there is favorable data emerging for the use of limus in the below the knee segment versus paclitaxel, which was our alternative when it came to drug delivery. But also, as Lorenzo mentioned, there is also developments with the development of stents of a suitable length and diameter, and the possibility of a sort of compromise between the idea of leave nothing behind and a suitable scaffold to allow some vessel remodeling in the form of the bioresorbable stent. So it's definitely an area we think of very active innovation with the industry going forward. What I wanted to talk about now, guys, just moving on, just perhaps for the last 5-10 minutes, was one of the things I've heard, and I've had the privilege of being able to talk on this across the world. It seems to be the same problems we're all having, and that is, how do you introduce new technologies into your practice without there being a hugely convincing evidence or cost effectiveness evidence? And it very much, I think, depends on who your managers are, who your unit is, or whether or not your government will reimburse these devices. So I'd just like one by one for us to go. If we could start with you, Wilhelmine, how do you introduce new technologies? What is your thought process in doing so, and what advice can you give our listeners who are interested in adopting them?
I think my foremost most important advice would be to collaborate. You can't do it on your own, because the most important thing is lacking, and that's evidence. So you must find another way, if you think it's a promising technique or a promising device, to introduce it, and you cannot do that alone. So make sure that you have your team backing you up. So you might see it in a conference or at a course that you're attending. Then ask the ones who have more experience all tips and tricks. Then select a proper case. Try for an introduction. So find an easy success, so to say. Don't aim too high. You want your first cases to be a success in order to keep your team motivated and your manager involved if you need to have reimbursement. So start small, be prepared, and team up.
Have you met with any resistance in your unit with yes. the introduction of technologies?
Yeah, it's always about money, right? Especially when there's no evidence. So of course, yeah.
So how do you convince the people that need convincing, whether it is your unit professor or whoever? How do you convince? What is it that we can learn from your experience in Maastricht?
You mean how
do you approach it?
I did it? Well, I can, as a very practical example, last year I visited Lorenzo's course in London, where there were some very good talks about IVL. I got all the talks and all the background there, and I talked to the ones that use the technology. Then discussed with my team, as I said, that this might be a very good technique for special indications, not to, especially for patients that we are lacking now a good treatment. For example, I used it first in patients with an isolated popliteal calcified lesion, where I didn't want to leave a stent. So a female patient with very fragile arterial disease. So this would be an easy success.
Yeah.
And then I arranged with the company like an introduction to try it, and got everyone involved and presented the results afterwards.
Okay. By Lorenzo's course, you're referring to the Find Your Algorithm course.
Absolutely.
Which I felt needed to be mentioned. Lorenzo?
Yes, I'm good that you mentioned it specifically. That's a Find Your Algorithm course. I can highly recommend it.
Lorenzo, can you tell us the difference between your experiences in London and in Florence with the introduction of new technologies? Can you just tell us a little bit about the difference?
Yeah, I would say that in the UK it was much easier. The thing is, like new technologies in the UK, if you demonstrate a little bit of data, there's as we said, you create an audit with your patients, you have a little bit of common sense, and it doesn't cost a fortune, then you can put you on the shelf. At least this was my experience. In Italy, every 5 years, there's a sort of a challenge between industries in order to provide devices. And once this is done, then the product which wins will be the one which will be used. And if you want to use another one, it's a huge struggle. So essentially, you need to, prepare the technology for the patient. And I said at the beginning how it's very difficult to plan what you want to use in a patient, because it's sometimes it's very much going the other way that you think. You pass just to mention, atherectomy devices needs to be used intraluminally. Then you go subintimately, you can't use the atherectomy device anymore. So it's very difficult to plan something from the beginning, and this really limits my practice. I have to say that in Italy, it's very much about, and it's not like in the UK, the chief. So if the chief is a guy with a good vision, and of course trust what you do, and that the main thing, you need to be a good lower limb specialist in order to raise your voice and say, guys, we really need that. If people trust you, then they will do it. If the chief is with you, then things can happen. But if not, Italy is much more difficult compared to the UK.
That's very interesting. I know there's certain areas of Europe whereby people are completely restricted. They may be completely sold on the technology, but they're completely restricted by the lack of government reimbursement. Therefore, it becomes completely impractical for them to adopt those technologies, even despite of, the growing bodies of evidence in its favor. So no, that's really interesting, Lorenzo. Thank you. It's good to hear that.
What happens, like, the technology is so new that it's many times very difficult to demonstrate that something works before putting it on the shelves, because the companies themselves want to put the device on the market as soon as possible, and this is not really feasible from an economical point of view. You can't use a device only if there are 5 years of evidence. Then the companies will all stop working. They won't produce any new technology because they can't afford the delay in creating a solid evidence And we as vascular specialists were very bad at doing that. We really don't care. We don't team up. We don't put big numbers in trials. And then that actually limits, the evidence while using a device. So you need to sniff the device and think that there's something that can be useful. Try it, audit your little practice, and possibly, share your results with the community and team up, as William said very well.
That's kind of what we are doing, isn't it? Globally, we are doing that. We're all doing our own little bit, and hopefully that experience does grow.
And we should learn from the cardiologists, right? Because they do it. Every new device is tested in a big randomized trial immediately. They have bulking evidence for all their devices, so it can be done.
Yeah, and another thing is, like, usually the money from these studies come from companies. So let's not let's talk about the elephant in the room. It's not like an individual physician will do it for the sake of doing. These studies are always sponsored by companies. I mean, maybe they're not. Of course, they're not sponsored directly. They're not saying, okay, now we're gonna. But they provide grants to allow the people to perform the technology and to do the follow up and stuff. So essentially, it's very difficult. There are some people, like I want to mention Professor Saratzis, who's really fighting hard in order to get to the government to get this funding. But at that moment, and the government has very strict criteria, so it's very difficult for us to keep up with the numbers that they want to put up in the studies. That's a very good tricky point.
So I was going to lead on and say that it sounded, for a change, Kaji, like we were doing something right in the UK compared to Italy. But tell me something. Have you noticed a north-south divide? Have you had any issues?
I can. I mean, there are certain. So I'm actually pleasantly surprised, Lorenzo. I assumed that Europe, everything was sort of sunny and you got to do anything that you wanted to. So that's a revelation.
If we're talking about food, yes, indeed.
But I think there definitely are centres within the UK that can get new technology through relatively easily. And there were other areas that really, really struggle. So I think there is definitely a differentiation within which in centres in the UK in terms of how you can uptake technology or how difficult or easy it is. And it is a little bit of a lottery with respect to that, sadly, but not insurmountable.
No. Okay. So just before we go on to Tjun, tell us a little bit about what your strategies have been. If there's something that you've been particularly convinced or interested by that fulfills a niche within our practice that perhaps doesn't or isn't met by anything else in particular, what has been your experience and strategies in order to adopt that?
So I think, especially if you're starting out in your consultant career, I think you need to get your basics right. So you've got to have a solid base before you step on to getting into new gadgets and new technology. And we've talked about it's collaboration. So get your team on board. You will have complications, you will have hurdles along the way. But if you can carry your team and be transparent and open, then that's half the battle. And if you can go to your medical director or go to your managers and say, look, my whole team supports this, and we're going to use it for very select cases, and we're going to audit. And we'll do the first 10 cases, we'll present our data, and actually, if there are problems and complications, then we will absolutely stop and rethink the strategy. I think you've just got to be open, carry the team, and collaborate. I think those are the keys, the key to getting any device or technology through, I think.
I think wise words indeed, Kaji. Thank you. Tjun, you mentioned when you came online that you were now working in the private sector in Singapore. Just tell us about the difference in your experiences when it comes to the adoption of these technologies, just as the last point.
So the word collaboration, I'm going to be very honest, and this could be quite controversial. There's no such thing as collaboration in Singapore. You do everything individually as a vascular surgeon, really. And that's been a big major challenge when I was at Singapore General Hospital. Research was very much single person driven, unfortunately. So it's not something that I wish it was. In the UK, it's very, very good. I mean, I remember the collaboration between different centers. I wish that was the case in Singapore. It's not, and the numbers are small. But the good thing about in Singapore is that even in the public sector, you as the physician are the boss, basically. You bring in the technology. You do not answer to managers. You only answer to your head of department. The way that I used to bring in new technology to justify it in front of patients, or at least to show, at least to show some sort of kind of audit trail, is to use what we call physician-initiated kind of trials, small trials of 25, 30 patients, and then follow them up very closely to show that we are doing something different, to see whether it makes a difference or not. And that used to be helped self-funded by some of the companies as well, which was very, very useful. So that's a big difference here. In the private, you are the boss, basically, which is one of the reasons why I left the public sector, because you become much more independent of what you do. But the numbers are much fewer than you would get in places like the UK. So, but bringing in technology, using what you like, is very much is your basically on your kind of onus to do. And you're not stopped really, unless, because the devices have to be what we call health services, basically HSA approved before you start using them. So, and then we get them very quickly, or you sign off on your own behalf. So it's much easier to use.
Thanks, Tjun. That sounds wonderful. I think one of the things that, just to sort of the last point on this, that I've utilized is very much a comparison to the alternative. So if the comparison to the alternative is a 19 ITU with thrombolysis, that's considerably more costly than the comparable thrombectomy device. And if you consider the risk associated with one versus the other, that is a good comparison as well. So these are some of the strategies that I've utilized. It's very much a cost, but also the cost overall, a global cost, not just to the unit, but to the hospital as a whole. That's one of the things that I think you can also consider. Now, Tim, I'm really sorry. Our discussion went on and on and on and on, but maybe...
No, that's fine. And Mark, that was absolutely fantastic. There are a few questions. I'll just quickly run through a few of them. There's a few which were just asking for some clarification about terms such as IVL, intravascular lithotripsy, but I think we can skip over some of those. Someone's asking about Meher's emailed in saying, what about the role of GTN and calcium channel blockers in below-knee interventions? Have anybody got a comment on that?
I can take a comment. I mean, GTN is like nitrates, so essentially it's vasodilatation of the vessels. I don't think that, there's a big role in terms of a long-term patency of the vessels, because it's a drug that you give, it's taken by the vessel, and then the vessel goes back to what it was. So I think that GTN is important when you have like some sort of spasm or some sort of, like we said before, the slow flow phenomenon. It could be like some small particles down from the balloon, for example, from a drug on the balloon, slow down the flow. Then these are important, but in long term, especially the one intraarterially, given intraarterially, are not really making a difference.
Yeah, there's a couple of questions came in about distal venous arterialization. I suppose that's one end of a spectrum, really. Mark, do you have a view on that? Is that part of your practice?
It's something that we've adopted within the last 12 months or so, maybe slightly behind, but it is definitely for us so far been a very selective patient. We talked about no option patients, but what we're really referring to are those people that have a paucity of vessels that cross the ankle. And in those situations, I think there is, from what I've understood and what I've learned, is that there is within those patients a group of patients that may have a stable wound, one that won't require immediate debridement or surgery. There are those who I would say are anatomically suitable. So generally the understanding that I have is that there should be at least one vessel that reaches the ankle. And then where we were tended to take off for our DVA had been slightly more proximally, whether that was at the level of the origin of the AT or usually the PT, I think, in our practice. And then what generally we've done, without using the commercially available percutaneous deep venous arterialization technology, just because we didn't have it, we used an off-the-shelf.
It's unavailable now anyway for 2
years.
Yeah,
we can't have it in Europe anyway now.
It's going to be relaunched, I heard.
It's coming back.
Yeah, but we did our own version off the shelf, utilizing the components of each of those that we felt were in that. And actually, rather than using the over-the-wire valvular tome that was supplied within that commercial equipment, we just used covered stents through, self-expanding covered stents.
If I could just add
I think we're almost out of time now, so I'm just going to use the last few seconds just to thank the panel. You've been fantastic. and it's been a really useful discussion. I'm very grateful. If anybody wants to rewatch this, it'll be on our website within 24 hours. But for now, I'm just going to draw things to a close, thank the panel, and say goodbye to everybody from wherever you've joined us around the globe. Goodbye and thank you.
Thank you.
Bye.
Thank you.
Bye.